Professor Christine Thompson to teach you about the cardiovascular critical care. She has been in the clinical for quite extensive time. She is currently working in Stanford. So definitely you will get wonderful first-hand knowledge from Professor Thompson. So let's welcome her. Give her applause. Can you introduce yourself a little bit?
I'll be
that would
pleased
be
to.
nice.
Thank you.
Thank you so much.
I want to thank Dr. Lee for the opportunity to come here and share with you all three clinical areas that I have a lot of passion about. I started at Stanford as a new grad over 30 years ago, and left Stanford after I got a master's degree to actually have the advantage of an advanced practice position, because they didn't have that many advanced practice positions back in those days. So I've also worked at UCSF as a clinical nurse specialist for cardiovascular on the 10th floor. If you guys know that hospital, it's two hospitals glommed together. Very busy, tertiary quaternary center, just like Stanford. I also work for the Kaiser system, setting up the cardiac surgery and interventional programs at Santa Clara, which is their cardiovascular hub for the probably 20 hospital now, Northern California Kaiser Permanente system. So lots of experience, critical care too. I've been a CCRN for over 20 years, which is critical care certification. As you'll discover, if you don't already know, your hospital is going to really encourage you to get certified, especially if they're on their magnet journey, as they like to call it, because magnet certification, they look at the number of nurses who've gone on to get certified, and it's more than just taking extra courses and sitting for an exam. It's keeping it up over your years, because everything is so dynamic in healthcare. So I'm pleased to be speaking to you today. I hold a small departure from your agenda. We will talk about first acute coronary syndrome, secondly cardiac surgery, and then finally heart failure, which is the area I'm actually working in right now at Stanford. I'm the program lead for heart failure at Stanford. Many of you may know we were the first hospital in the United States to do heart transplant back in 1968, and the first to do heart-lung combined transplant, etc. We have a very robust program, big patient population, and I get to see patients on the inpatient side as well as in clinic in shared visits. So anyway, enough about that. You do need a break, so I'm going to try to pause it, watch the clock for 2:30. It'll probably be just as we're starting our into cardiac surgery. So I want to make sure you get your breaks. I know how that is. It's hard for nurses and future nurses to sit for very long. So acute coronary syndrome, is that a familiar term for you all? Well, it's actually an umbrella term that encompasses three diagnoses that we'll talk about. What we're going to talk about is what is the pathophysiological substrate for acute coronary syndrome. That'll be a brief review, as I assume you've had this already in your anatomy and pathophysiology classes. And we'll talk about the brief clinical diagnoses, two kinds of acute MI, acute myocardial infarction, and then a third diagnosis called unstable angina, and how we actually make the distinctions between the three clinically. And we'll talk about the acute and long-term treatment strategies for acute MI, and state what the key nursing focus would be for patient monitoring and assessment. So again, acute coronary syndrome is part of that large spectrum of ischemic cardiac disease. Ischemic, is that a familiar word? Right? Basically, ischemia refers to insufficient supply to meet the demands of the heart itself, as well as the tissues and organs of the body. So USA is an abbreviation we use for unstable angina, and acute AMI represents acute myocardial infarction. So what are they? Well, these three entities. The first two, again, are versions of acute MI. We call them STEMI and NSTEMI, and that stands for ST segment elevation MI and non-ST segment elevation MI. So what that tells us is the distinguishing factor is the presentation on ECG, 12-lead ECG. We make that distinction on 12-lead ECG. We don't look at rhythm strips to determine ST segment. And I know you've had some exposure to ECG. We won't spend a lot of time on it because we don't have it to spend, but I wish we could. But ST segment is a short, usually isoelectric segment that follows the QRS waveform on ECG. And when it's elevated over 2 millimeters of mercury, which is 2 little boxes, that's considered significant, and it's usually indicative of myocardial damage, ongoing injury, right now, real time. When it's depressed, usually by 2 millimeters of mercury, it's usually, and I say usually, indicative of ischemia, not necessarily injury. But anyway, if the person has the clinical findings of acute MI that does not have ST segment elevation, and they're usually treated medically. And today, in 2015, most patients presenting to an emergency room with acute MI don't go to an ICU or coronary care unit, which is a high level of care where there's 1 or 2 patients per nurse. They usually go to a telemetry floor, or what may be called an intermediate ICU, where the ratio is 4 patients to a nurse or 3 patients to a nurse at Stanford. We have 3 to 1 at Stanford. And the converse is a patient who presents, let's say, to a small community hospital. I live in Pleasanton. If they come to Valley Care with acute MI, well, actually, that's not a good example because they now do primary PCI. But some hospitals do not have a 24/7 cath lab to take patients to do an angiogram, an angioplasty, in the setting of acute MI to open up that culprit vessel and restore blood flow. Because that's our mission, is to revascularize that territory of the heart that's at risk so that it can go on to become, and for the person's lifetime, viable myocardium that functions instead of scar tissue. So patients that present with STEMI are usually routed in a hospital like Stanford or Sequoia or Valley Care Valley Medical in San Jose. They go straight to cath lab if they have the constellation of findings that indicate that they're in acute MI. So what are the symptoms? Well, first of all, what are our treatment goals? First of all, we want to relieve any kind of angina, whether that's chest pain or jaw pain or back pain, because angina can have many presentations. We all have seen the Hollywood movies and the TV shows where the person has what we call the Hollywood heart attack, where they're clutching their chest and they feel like there's an elephant on their chest. Well, guess what? A lot of patients never have that experience, particularly women, and particularly patients who are diabetic and who may have neuropathies. They may not experience substernal chest pain, and sometimes their anginal presentation may be jaw pain. We've had patients say, I got up in the middle of the night and I had this horrible toothache, and actually it was their anginal presentation. Who knows? But so why do we want to relieve that? Well, we don't want people suffering, but also when you give some morphine, for instance, in the setting of acute angina or MI or a nitroglycerin, you're vasodilating to allow more blood flow, and you're also quelling that fight or flight response, which actually hurts the heart. You know, that sort of neuroendocrine flush of adrenaline, etc. That can actually be harmful rather than helpful to the patient. We certainly want to prevent MI and mortality, and we want to preserve, our goal is time is muscle. We want to preserve as much viable myocardium as possible so patients can go on to live good quality of life. That's what we would all want. So I won't spend a lot of time on this, but I'm sure you're pretty aware of this, but coronary artery disease is the biggest killer of men and women, and we're reminded of that every February because it's Heart Month and Valentine's Day, and there's the Red Dress campaign to let women know we're much more likely to suffer stroke or a heart attack than any form of cancer. So it's very important that we pay attention to this because it's a big public health issue. And many patients will have what's called a silent MI, and it's discovered only after the fact at some point in their history when they may have a 12-lead ECG, and one sees changes indicative of past damage to the heart. And they've never known that they had a heart attack. So it's a big issue, and it's very prevalent in our country and in the Western developed world. Every 25 seconds, an American will suffer a coronary event, and about every minute, someone will actually die from it. And if you're interested in these statistics, you can easily look them up. They're on the web under American Heart. Every year they update They'll tell you how many strokes there are. They divide it up by demographics in different parts of the country. And it's good information for us to know, because as clinicians, we're all going to be ambassadors, not only where we work, but in our communities and for our families, about what are the heart healthy habits. And guess what? We think some of those heart healthy habits actually help preserve, stave off dementia. And we have, as you know, we have an aging population, particularly I think in the Bay Area, because our climate is good. We have a nice demographic here. People are fairly affluent, etc. So hospitalizations due to acute coronary syndrome, over 1.5 million for acute coronary syndrome. Of those, many more patients, almost 4 times as many patients, will be hospitalized with either unstable angina or non-STEMI, what we call non-STEMI, non-ST segment elevation MI, which people often think of as the more benign form of MI, but it actually is not necessarily, and I'll show you why. So many more than actually present with ST segment elevation MI. And these, again, are the patients that would be immediately routed to a cath lab, or in the presence, if there's no cath lab availability, they would get clot-busting drugs that we call fibrinolytic drugs, like TPA, to bust that clot and restore circulation. There's far fewer of those. And then, as you can see, well, the numbers are climbing, but men usually outstrip women in the younger years. This is also true of heart failure. By the time you get to 65 or over, women outstrip men, or start to. Actually, they don't for this. They do for heart failure. And one reason why is women, it's thought that estrogen confers some cardioprotective effect. And after menopause, women start to catch up. And usually when they present with cardiac issues, they're like 10 years older than the average man would be. But interestingly, they don't do as well with either bypass or interventions in the cath lab, because women tend to have smaller coronaries, smaller diameter. So the statistics of how their outcomes is not as good as men, believe it or not. Myocardial infarction is cell death, and due to prolonged ischemia. And when the myocyte dies, it dies. We don't really have a viable stem cell program that works yet. That's all in the investigational stages. And sometimes when it's bandied about in the literature, it gives people the false impression that they can go in and get an injection of stem cells and everything will be fine and they won't need a transplant. Well, that's not true yet. When the myocyte dies, it becomes, just like any other injury to the body, scar tissue, fibrotic scar tissue. And that scar tissue in the heart creates 2 problems. One is it doesn't transmit the signal for beating, from the sinus node, cell to cell to cell transmission that coordinates the rhythm of the heart. So it doesn't, and it actually often becomes a focus for aberrant arrhythmias like PVCs or VTAC, because the impulses have to travel around this dead tissue in the heart. And by the time it gets to a certain point, we call that reentrant arrhythmias. It re-stimulates cells that are in the refractory stage. So it's probably more than you need to know. But bottom line is they can contribute to arrhythmias, and it also doesn't contract well. It's sort of just like flawed tissue that doesn't help in function. And it can happen as early as 15 minutes after the ischemic event. So that's why we're so focused on telling patients to call 911 and don't wait, don't try to tough it out if they have persistent symptoms, and that may also be accompanied with sweating, diaphoresis, nausea many times, chest pain, shortness of breath. Many older women often present with shortness of breath and sometimes epigastric pain, which they go to the ED, we'll take some Mylanta and see if you don't feel better kind of thing. That's changing. The focus is changing on how women are approached and assessed and treated, but for a long time, women were undertreated and also underrepresented in research studies, especially around cardiac. So then we also classify MI about where it's located. You know how the heart is oriented in the chest. It's actually kind of tilted in 2 planes. And we have the inferior wall that faces the diaphragm. That's composed partly of right and partly of left ventricle. So once you get to know the circulation of the heart, when you look at an ECG, you can actually see where the damage is, because there are certain leads that are associated with certain anatomic portions of the heart. So we might say it's an anterior MI, which is bad because most of the well, a lot of the anterior can be left ventricle, some of it's right, lateral, posterior, and so on. So, and then how big is it? Hopefully it's very minimal. We like to minimize the damage. We want to store good blood flow and have a good functioning heart. And then temporality. Acute MI obviously is here and now, ongoing. It's an emergency. Is it a healing MI, 7 to 28 days out? And is it healed 28 days beyond that? Years ago, you went to Stanford when the old stone building first opened, the famous one with the fountains, 1960, and you presented with a heart attack, you'd be put to bed. We didn't even give patients an aspirin, and I wasn't a nurse then, believe me, but we didn't even give patients an aspirin. We didn't really, it's just like bed rest, that'll fix you kind of thing. And we found out, guess what, bed rest is a very bad thing, even for people with acute MI. Anybody, any age, for 48 hours or longer in bed, you start to develop atrophy. And then you have illness on top of that your body's coping with. It's a very bad thing. So we've come a long way in the treatment and approaches to MI. So we have our circulation. You're fairly familiar with this, but here's the aorta. And it's pretty simple. We have a right and left ventricle, or right and left heart. We have right and left circulatory systems. And because the left heart is much thicker, it's 3 times thicker on the normal wall than the right ventricular wall, or right atrium, which is quite thin, because after all, its job is only to pump blood to the lungs. So it has a low pressure circuit it's working with in the healthy heart. Left side, hard job, much harder job. It has to overcome aortic pressures to eject blood through the aortic valve into all the tissues and organs of the body, the arterial system. So it's thicker and it's more demanding of circulation. So coming off the aortic root, you have a left main that quickly bifurcates into the left LAD and the left circumflex coronary artery. All these things, and the cartoon doesn't depict it very well, have robust branching systems from the LAD, which comes down to the apex. There are branches that feed the septum, and more importantly, the conduction branches, what we call the left and right bundle branches, that go parallel down the septum to help innervate and coordinate the function and the beating of the heart. Right coronary artery obviously nourishes the right ventricle and the right atrium. It also has little branches in most patients that feed both the sinoatrial node and the AV node. Sinoatrial node being up here, right, the pacemaker of the heart, the ESA node, and the AV node is the backup pacer of the heart. So if you're a nurse and you recognize or know the patient's having had an occlusion or intervention to the right coronary artery, you're going to be thinking, I need to look for interruptions in the rhythm, usually bradyarrhythmias, if that part of the heart is affected, especially if it's very proximal. In other words, it's very close to the aorta. That means all the territory distal to it is at risk. So that's how nurses can get tuned into what am I going to anticipate in the care of this patient. And then we won't spend time, because 12 lead is pretty advanced stuff. But I highly encourage you to consider studying it at some point in your careers, because it's really interesting. And it's a tool that's been around since the 1930s. That's the 3x4 layout of the ECG, but it can tell you a lot about the structure of the heart, interestingly, give a lot of clues to the heart. And it's interesting, I think. So the shaded areas, like if you see changes in these particular leads, it's talking about various portions of the heart, whether it's septal, anterior, or inferior wall. And because the inferior wall, represented by the leads 2, 3, and AVF, are fed by the right coronary artery, then you kind of know which part of the heart is at risk and what to expect, i.e. bradyarrhythmias, or the blocks. So here's a normal coronary artery. This is what we'd like to see. Nice thick muscular wall, intimal layer here. Nice, wide open lumen. So the mantra is, bigger is better kind of thing when you're talking about coronary arteries. We want good blood flow. And unfortunately, given our Western diets and the tendency of a lot of us Americans to not exercise very much, I wouldn't say that's true in the Bay Area, but it is nationally. And you'll find out when you start studying this that there are pockets in the United States, like the Southeast, or Louisiana, for instance, where there's a lot of coronary disease because of the diet and because a lack of sort of a culture for heart healthy habits. And so what happens is plaque builds up. And it builds up, actually it starts on the surface of the artery, on the intimal layer, and with the action of phagocytic monocytes, etc., it actually gets embedded under the intimal layer, inside the wall of the heart. A lot of people imagine the plaque is just this yucky, gross yellow stuff just sitting there in the bloodstream, and it actually isn't. It actually gets underneath the intimal layer, and over time grows. It develops a cap. I'm going to really simplify this. A fibrous cap, which at some point may rupture. And when it ruptures, the cap and the stuff underneath kind of flaps in the breeze like a flag, and guess what that does? It starts the body's coagulation cascade to kick in. So first you have deposits of, or aggregation of platelets, then you have red thrombus forming, and you have acute MI, because that red thrombus ends up including the entire vessel, and that would be acute MI. Sometimes the body's own fibrinolytic system will dissolve that MI, so patients have what we call stuttering MI. They'll have the pain, then it kind of goes away by itself, and it comes back, because the body does have its attempts to deal with it on its own, but usually we want to train our patients to get seen right away. What's interesting too is the plaque that's more likely to rupture. It's not the 90% occlusions that an interventionalist in the cath lab is going to open up and stent, angioplasty and stent. It's going to be the 45 or 50% occlusions that are not, subtotal, that usually don't get intervened on, that are more vulnerable. So you'll see stuff in the literature about the vulnerable plaque that's actually more likely to kick off acute MI. So I just described for you how this happens. And this is how awful, the buildup can get, where this is what's left of the lumen of the vessel, and all this is plaque. And so that gets calcified over time in the vessel. And other portion, of course, there's an inflammatory response. Anytime you have an insult to the body, even this own endogenous system kicking in, there's inflammation. Sometimes there can be vasospasm. And doctors go in the cath lab with these instruments, the angioplasty balloon, and they inflate the balloon at many psi, almost like tire pressure, to open up this small 4-millimeter artery. The body's tendency is to recoil. An artery rhabdoid, anyway, I'm going into a lot of detail there. But there's a lot of things to surveil for. But today, since most patients are getting stents now, that didn't used to be the case. The stents are like internal scaffolding that keep the arteries from recoiling and keep the vessel nice and open. But because it's a foreign substance, patients often have to take a super aspirin like clopidogrel or Plavix. The recommendations are usually for a year after they have stenting to prevent platelet aggregation, prevent the body to say, this is a foreign substance, I need to deposit thrombus here. That's the body's tendency, so they put them on Plavix, or sometimes they have drug-eluting stents that elute slowly over time drugs to prevent clotting and new intimal buildup that causes blockage. And this is an artery, and this is completely full of blood clot. So, how do we make a diagnosis? For acute MI, even in 2015, there's usually 3 components that comprise the diagnosis. One is the presentation. It's a patient's clinical story, and you couple that with the risk factors. What are the risk factors for cardiovascular disease?
High cholesterol.
High cholesterol, diabetes, smoking, big one. Pardon? Obesity, yes. So definitely obesity and inactivity.
How about ethnicity?
There can be, yes, that's true. There are some ethnic groups that are more prone to a cardiovascular disease. An example, and they can be very fit and do all the right things. Example would be people with Indian ancestry living in Fiji. There's like a pocket of people there. There's other people that seem to have a genetic cardioprotective effect. They've discovered a pocket of people living in Italy that don't necessarily do all the heart healthy things, but they seem to have some genetic protection. So yes, heredity. So there's modifiable and non-modifiable risk factors. We can't help our ethnic health or genetic hand we were dealt. We can't help that we were born female or versus male, or that we're all getting older every day. So age also contributes. But there are the modifiable ones that we want to stress for our patients and for our loved ones about. These are important things to pay attention to. So the clinical evaluation ECG findings, which, by the way, may be negative when they first present to an emergency room. There may be no acute changes, so the patient will be there for observation. We draw blood for what we call biomarkers, typically cardiac troponins, and different hospitals or different settings use different assays and different components. So I'm not giving you strict parameters for the biomarkers because it depends on where you work and what the labs are. So you'll need to learn what they are for your lab. And then sometimes besides cardiac troponins, we use creatinine phosphokinase, or what we call CPK, and the CPK MB fraction, which is specific for myocardium. We pay attention to those things. So 12-lead ECG is really a cornerstone to diagnosing and triaging patients that present with acute coronary syndrome. And then risk assessment, I'm going to go through that. We just talked about the risk factors. They can be risk assessed into buckets if we want to. And we're going to send them to an ICU or have very intensive monitoring for this patient if they start to show signs of cardiogenic shock. And that would be hypotension, showing signs of poor perfusion peripherally, so cool, clammy, edema when you listen, and then growls, or what you call crackles when you do your lung auscultation. And if their heart rate, if they're tachycardic because they aren't perfusing well, that's the body's compensatory mechanism to improve perfusion. So this is a little cartoon kind of illustrating what part of the heart gets damaged first. Our circulatory system, when you look at the heart, if you were to see a graphed heart yourself, you would notice that the big pipes, if I can call them that, are on the outside, on the endocardium. Excuse me. The epicardium, the surface of the heart, and the small branches delve in through the walls to the endocardium. So when there's a threat to the heart, the first part to die is going to be the endocardium. And that's why you may have heard terms like subendocardial MI. That meant this part died, but it wasn't what we used to call transmural. We don't use those terms anymore. We now say STEMI versus NSTEMI, which drives the treatment and the urgency of the treatment. The ECG also shows us, like I talked about, ST segment depression, which usually is associated with ischemia. Injury, this is the ST segment, so aberrant looking that the whole QRS looks weird. This is ongoing injury, do something, or this part of the heart's going to die. And then infarction, this is not here and now. This is what I talked about with an ECG change that might be seen a day out, 10 years out. But it indicates part of the heart died. It's called a Q wave, and there's clinical definitions of how deep it has to be and how wide it is, because there are some small Qs that are normal in some adult ECGs on certain leads, etc. So you get to learn all that. But I just want to point out to you that you can tell quite a bit by looking at a dynamic ECG, and for definitive diagnosis, we look at the static 12-lead ECG, which is the 10-second snapshot of what's going on with the rhythm of the heart. And these are the various patterns that we learn about with infarction patterns. So, and this is the ECG criteria for STEMI versus NSTEMI. We actually measure boxes. Each one of those little boxes, either on the monitor paper or on the 12-lead ECG, is 1 millimeter. In terms of the y-axis, your waveforms indicate voltage, how much voltage there is. So with some patients that have a lot of damage to their heart, they may lose voltage because they've had a real insult to the heart. So the main message is time is muscle. I know you've heard this because we as lay people also hear it with the various campaigns around February. But it's really true, and we really need to encourage our patients to call 911. It's very scary when you hear the stories about patients who are probably in the throes of acute MI, or maybe even in VT, ventricular tachycardia, who have driven themselves, sweating profusely, to their local ER. It's like, oh my God, I don't believe that happened, you know. And as a wife or a spouse, you probably don't want to be driving them either. It's much better to call 911. Although, amazingly, even patients who have a history are reluctant to do this because they don't want the neighbors peeking through the curtains, you know, the big to-do of having an ambulance roll up. But we need to encourage it. And also the stroke, obviously, because time is brain. So therapeutic options, we actually are benchmarked. Hospitals have to report this data to a national database. how long well, not time to treatment, that time when the patient stepped into your emergency room door. They call it door to first ECG, 10 minutes, it's a benchmark. From door to up in the cath lab, insertion and inflation of the very first catheter balloon for angioplasty, that's got to be 90 minutes, within 90 minutes of hitting the ER door. So there's very intense benchmarking and documentation of this. And of course, the goal is sustained blood flow. This also emphasizes how important it is to present early and not ignore signs of impending MI, because this is the benefit in myocardial mortality. In other words, this is survival. Survival goes down within hours. This is myocardial survival, maybe patient survival. So it really matters, and this is old, but it's still true today. We really need to get the message out. And then this is infarction size versus time to treatment. And no surprise here, there's a very linear relationship between how long it takes before the patient presents and treatment's initiated. This is in minutes, 50 minutes, 120 minutes, etc., to treatment, and how huge our infarct is. And we want to obviously limit infarct size. So symptoms are variable and unfortunately rather nonspecific, because lots of people get nauseated for various reasons, right? But when you see nausea and diaphoresis in somebody who's got the risk factors, definitely hemodynamic instability, anxiety is very commonly associated with acute MI, acute events. And you won't necessarily know about dysrhythmia unless you have them hooked up to a monitor. And this other D, denial, big one. A lot of people deny that they're having a heart attack, so therefore they delay. When you're, as a clinician, assessing chest pain, it's like any other pain assessment. Remember the PQRST for pain? It's similar for chest pain too. What's the quality of the pain? Patients will use descriptors like burning, crushing, not always, but many times they will. Location, you can actually have anginal pain that's posterior chest, not even anterior chest. And we often get worried about that. We'll do bilateral blood pressure assessments because sometimes right between the shoulder blades, if there's severe pain that's often described as stabbing, they could be having a dissection of the aorta, which is obviously an emergency. So radiation, the pain may be substernal but also radiate, typically to the left arm, doesn't always have to be the left arm, and typically the anterior aspect of the left arm. They could have only shoulder pain, they could have only jaw pain. So we get to learn what the patient's anginal presentation is. And as I mentioned, some women, particularly diabetic women, may not have any pain at all. They present again with shortness of breath. Maybe a new arrhythmia like atrial fib with rapid ventricular response, a very high heart rate, which is very hard on the heart because it's whipping, having to beat so fast and it doesn't have time for filling. Duration of symptoms is the pain onset, less than 5 minutes. Many patients go home with nitroglycerin. Have you guys ever seen the nitroglycerin sublingual tabs? Do you know how to give it? Or how to teach a patient how to give it? Sublingually. Let it dissolve. If it's a potent tablet, it should slightly fizzle or burn, even like a slight burning, not a painful burning, but you feel it kind of doing something on the tongue. Wait 5 full minutes by the clock before taking a second tablet, and you can take up to 3. Or again, waiting 5 full minutes. Many patients get panicky and don't wait, and end up syncopal or near syncopal because what does nitro do? It's a big potent vasodilator, particularly on the venous side, but also the arterial side, and patients may syncopize or faint, pass out. So it's important. I actually teach them to sit down when they're taking it and literally watch the clock. The other important thing about nitroglycerin is it needs to be in a very tightly sealed container. So it usually comes in a little brown glass jar. It's brown for a reason, to shield from light. So it should not be stored in direct light, and it should be always tightly capped because it will lose its potency pretty easily. It's really a delicate drug. So intensity, we have our patients rate all their pain. And remember, pain is the 5th vital sign for any nurse, any clinician. When you're assessing vital signs, you're expected to assess for pain. It's certainly in the acute hospital setting. And then if you've intervened for pain, the patient has pain, you must come back within an hour and document what the relief they had or not with the intervention you provided for the pain. So that's a very strictly looked at thing in the hospital documentation. So there are many cardiac causes of chest pain besides angina. So what's the difference between regular angina and what we call unstable angina? Well, regular angina is usually associated with exertion, like the person carrying a heavy sack of groceries up several flights of steps and they develop chest pain, or shoveling snow, right? But unstable angina has several definitions, and I'll talk about that. An unstable angina, which is one of your diagnoses under the ACS umbrella, is something to pay attention to. People often think, it's no big deal. Why does this patient even have to be in the hospital? So they have unstable angina. Well, the only difference between them and an MI patient is they didn't have positive cardiac troponins, and they're actually a hot potato. And they're usually on the telemetry floor with a nurse who's looking after 3 other patients as well. So there are patients to pay attention to actually quite a bit. Likewise, the patient who has an MI treated medically on the telemetry floor, not in an ICU, didn't go right away to cath lab for revascularization because it's usually not necessary. It may go back to cath lab for imaging and possible intervention later in the course of their admission, or they may actually go home and come back in as an outpatient for their cath. They're a hot potato. Why? Because the patient, they're more likely to reinfarct within 1 year, 12 months, than the person who presents with an ST segment elevation MI. So we actually need to take all these patients fairly seriously. And then Prinzmetal's angina is a variant of angina that's caused by vasospasm, and they're treated with calcium channel blockers. Of course, myocardial infarction, pericarditis. Anybody who goes to cardiac surgery usually has if it's an open case, they're going to have their pericardium cut open, and the pericardium can inflame post-op while they're recovering from their cardiac surgery. And so you'll see changes on ECG for this, but they'll be global across all the ECGs, so you know that it isn't associated with a certain territory. And it usually goes away on its own pretty well. And of course, what I mentioned before, aortic dissection, that's an emergency. It can be up at the first part of the arch or the later part of the arch. And it's typically described as a knife-like or tearing pain, usually the posterior chest between the shoulder blades. So angina, again, what causes it? Well, it's basically ischemia. Just like when we were children, I don't know if you ever did it, the kids on the playground would say, I'm going to give you a donkey bite or an Indian bird, and they would twist your, and it hurt. It was basically they're creating ischemia on your arm by twisting your, I remember doing that. I'm not doing it, being a victim, more likely, but anyway, lactic acid and carbon dioxide accumulate, and they stimulate the nerve endings. That's what actually causes the pain. But there are patients that have silent ischemia. And there are lots of actually nursing studies by Dr. Barbara Drew at UCSF that show that patients can infarct or have ischemic episodes at night and they're completely asleep. They don't never wake up, and they could even have an infarction. So that's the importance of continuous monitoring for patients at risk. And especially being able to monitor in more than one lead at the same time. We can look at 2 different planes of electrical activity in the heart and get lots more information. And then the concept of anginal equivalent. Some patients, again, don't get substernal chest pain. Their angina is somewhere else in the body, and places people don't often associate with angina. Like I said, jaw pain, that one patient mistook for a toothache. What do we do for angina? Well, if it's stable angina, the patient usually learns to stop doing whatever it is they're doing. And usually, eventually, these patients get worked up and evaluated for are there interventions that will benefit them, like in elective angioplasty and stenting. Or they're given nitroglycerin and instructions on how to take the nitroglycerin. And if they have variant angina, they may have calcium channel blockers, which relax the vessel walls and discourage the spasm that's causing their angina. But, and there are gender differences. I talked about women being a little bit trickier to diagnose because they tend to have atypical presentations. These are all very vague symptoms. Diabetic patients, because of neuropathy, may not have the pain that one would expect. And they also tend to have very diffuse disease. Sometimes they'll have a cath and their coronaries will be deemed clean. That's only true of the large epicardial vessels. They actually have smaller disease in the smaller vessels that can't be intervened High-risk characteristics will be your patient that are presenting as cold and clammy, hypotensive, tachycardic, looking like they're going into impending cardiogenic shock. You can do some assessment just with your stethoscope if you're hearing crackles and you're hearing what we call extrasystoles of S3, S4, and that may be something you've never heard of, but there are extra heart tones that have to do with either volume overload or stiff, non-compliant ventricles. That tells you the LV isn't working that well. And then, again, using your assessment skills and just nothing fancy, looking at jugular venous distension in the neck when the patient's sitting up at 45 degrees. You're seeing pulsations up to the jawline. This person is hugely volume overload, the heart's being challenged, etc. Or if you start to hear new murmurs that you didn't hear when you were auscultating heart tones as well as your lung sounds, it's often a nurse who might be the first one to pick up on a new regurgitant murmur. And mitral regurg can be an emergency because it can happen in the setting of acute MI where the vessels feeding the papillary muscles that support the mitral valve dysfunction, and you have a new acute MR, that could be an emergency, where a chronic MR is not an emergency because the heart's had a lot of time to get used to that. So markers of cardiac injury include, we talked about troponin I, and that's the one you're going to see mostly used. Cardiac troponin I, there's also cardiac troponin T, and the assays vary and the ranges of what's normal to not normal. I'm just showing you one particular range. It's valuable because it increases rather readily in the setting of acute MI within 3 hours. It will stay elevated for a week or sometimes even 10 days. And then the CKMB, which is a particular isoform of creatine phosphokinase that you'll see on the lab report. It's better sensitivity the first 6 hours. We often use it to quantify the extent of damage besides doing imaging like echo. And then this is just, you can look at your leisure, a comparative chart showing when, days after onset of MI, that the various biomarkers peak. And you will see that some patients, in your practice, you take care of end-stage renal patients or patients on dialysis, they often have CK leaks. We actually think they have myocardial damage because of their kidney disease. So they usually don't reach the threshold to say this is something going on with the heart. They're just low leaks. Normal people shouldn't have any troponin leak, don't have disease. And this is showing the huge scar tissue in MI. This is all fibrous tissue. Again, doesn't participate in contraction, doesn't participate in the transmission of the pulse per beating heart, your ECG rhythm. And then this shows you how you make a diagnosis. Basically, if you're positive MI, you have the positive cardiac markers for both types. The only distinguishing factor is whether or not you have ST segment elevation or not, or ST segment depression and T-wave inversion indicative of ischemia. And so why do we make a difference? Because this tends to be smaller, to be treated safely medically, and this one tends to require immediate revascularization, i.e. going to cath lab. We call that primary percutaneous coronary intervention, or primary PCI. This patient will go be bedded on a medical unit, usually a telemetry unit, and will be treated medically and maybe worked up for their heart disease. Diagnostic tests, non-invasive or invasive. I don't think I have time to go into all these. An echo, as you know, is nothing more than an ultrasound of the heart. And with one of the cardiologists that I work with a lot, he has one that's the size of like a small iPad, or like an iPad mini. He just flips it open in his hand to throw here, the patient's sitting on the exam table. And it's lovely. They look at the superior vena cava to see if it collapses or it doesn't collapse on inspiration. If it doesn't collapse, the person's probably volume overloaded. It gives you like a little quick snapshot or window into the patient's heart right there in clinic. And we have two kinds of echoes. One's the transthoracic, where they rub the probe over the chest, right? I'm sure some of you may have seen this happen already in your clinical rotations. Very easy to do. They can use color Doppler. They can assess wall motion, function of the valves. They can do an estimate of ejection fraction, cardiac output, all that good stuff. They can also, there's another type of echo in which the patient actually swallows the probe. And the probe, remember the esophagus is right behind the heart. And they swallow the probe, and the atrium, the left atrium, where you might tend to have clot, or you might tend to have air if you're in open heart cardiac surgery, left atrium is completely posterior structure, the way the heart's tilted in the chest. So you can't see it very well, visualize it very well if you're doing a transthoracic echo. But they swallow this little tiny probe, and it sounds awful to be swallowing a probe, but it's very small really, like a little pellet on a string, and it sits there. And the job of the cardiac anesthesiologist during heart surgery is to completely watch and make sure there's no air sucked into the heart that would cause embolism and death during the open case, etc. And we use the TE echo when we're going to cardiovert somebody out of their atrial fib, because we want to make sure there's no clot lurking, right? When you're in atrial fib, you're doing this, right? Quivering. They aren't squeezing in a nice synchronized way with the ventricles. So you have ventricular synchrony and timing working together. Remember, the atrial contraction contributes about 20%, maybe more, filling to the ventricle. So if you have your atria doing this, blood starts moving very aberrantly, and it's a setup for clots. You're always thinking about the risk for stroke. And for most patients, even in chronic atrial fib, the standard of care is anticoagulation, lifetime, unless there's a compelling reason not to, a safety reason, like they're at risk for falls, they're demented, they won't go for their INR checks, you know, they're non-adherent to coming in for their lab work. Being on warfarin is no picnic. It's a tricky drug to manage. So there's a host of tests that we can do and interpret. The goal, again, is to optimize blood flow to the myocardium. We can do this with the help of medications, like vasodilators, principally nitroglycerin, right? We can give nitro a million ways. We can give it as a sublingual tablet. Paramedics give it as a spray in the field or in the emergency room. You can get it IV as an infusion. You can get it as a tablet, right? Long-acting tablet like Iserdil or isosorbide nitrate, isosorbide mononitrate, and so on. So lots of ways to deliver nitroglycerin. Clot-busting drugs, antiplatelet drugs, and the simplest one is the one you see on TV at dinner time when you're watching the man playing basketball with his son having a heart attack, and then he knows to go take a bare aspirin, right? Because aspirin is antiplatelet therapy. We have the Plavix, clopidogrel, and Pasigrel, which are called the super aspirins. They're rather expensive, although clopidogrel is now available as a generic formulation, but stopping that first step in the coagulation cascade, which is platelet activation and aggregation, can help prevent clots after MI or future clots. And then antithrombotic agents like bilirubin in the cath lab, like Coumadin or other Xarelto or other anti-clotting agents. And then finally, using the mechanical system, stenting, or the different tools, the armamentarium of the doctor in the cath lab to revascularize. And sometimes they even can extract the clot. And then finally, open heart surgery. So strategies to reduce myocardial oxygen demand are, well, basically self-assessment about exertional tolerance for the patient. You know, we want patients to move. We don't want them languishing in bed. So we get them up in the hospital pretty readily, even after cardiac surgery these days. They're usually extubated and up in a chair the day of surgery, believe it or not, or certainly the day after. No more languishing in bed. Move these folks. And start cardiac rehab in the hospital, with the advantage of being able to monitor them in their response to walking around the units and so on. Even in the ICUs. There's huge literature about early mobility in ICU settings. Beta blockers like, what's a beta blocker? Metoprolol is a cardiac-specific beta blocker. Carvedilol is also one. It's also called Forig. We don't use the non-beta block, cardiac-specific ones very much anymore, like sorry, bring it to my mushy. Because we don't use it anymore. Propanolol, right? Drugs they might give for like a panic attack or whatever. We want beta-1 specific because we don't want to affect patients who may have vasospasm or bronchospasm. So the other drugs are non-specific. They can affect the beta-1, beta-2 receptors. Remember, you got one heart, two lungs. So we want beta-1 receptors, and carvedilol has the added advantage of also being an alpha agonist, meaning that it causes vasodilation, improving blood flow. So it has a double whammy effect. And so beta blockers are not only suggested, they're a core measure. And in hospital patients, if you're a patient with an MI, in your chart, it better darn say that either you're on a beta blocker at discharge, or it wasn't prescribed, and these are the reasons why. These are the contraindications. The same thing for, anyway, so that's a core measure, what we call a core measure for for acute MI, but it's also a core measure for heart failure. Patients with heart failure, it's a standard of care to put them on beta blockers. And it may sound crazy, like why would you block a beta receptor in someone whose heart is failing? And I'll explain why that is, but we do. We actually do. And then calcium channel blockers for some patients. Why? These drugs slow the heart rate. You want to keep the resting heart rate modulated. There's no reason in the world a patient laying in bed should be attacking away at 100. You should wonder why that is. Why is my patient at 100 and they're just laying there in bed? Are they febrile? Are they hypovolemic? Are they in pain? Or is this the way they always are because they're in atrial fib and they have a higher? Even so, if they have a cardiac issue, we want to keep that heart rate down. And a lot of abundant literature to show that keeping the heart rate down benefits patients for two reasons. One is slower heart rate, less demand of the myocardium itself for its own perfusion. Number two, slower heart rate, you have more time during diastole for chamber filling. If you're going tachy, you've shortened diastolic filling time, and you're flogging the heart, so it's demanding more and more, and that ends up being a downward spiral, especially for someone with compromised heart. Nitrates, vasodilators, enhance blood flow. Intra-aortic balloon pump is a mechanical intervention sometimes employed for patients who go into cardiogenic shock. And I can show you a picture of that later. And also for patients who arrest, or for patients who are having cardiac surgery, we often cool them. We cool their bodies down, and we cool the myocardium as well. And that's to lower myocardial oxygen demand. This is a little schematic that shows you how patients are treated. The main point I want to show you on this slide is that I told you already that more patients present with the N-stem, non-ST segment elevation, MI, or coronary syndrome. These patients, so there's many more patients in this bucket than in this bucket. In this bucket, the patients tend to be older, they tend to have more known risk factors and known coronary artery disease, and they may have had a series of events over their lifetime or to date. This patient, this is the STEMI, the ones that we send to cath lab or do immediate revascularization, they tend to be younger, middle-aged, and many of them die before they ever hit the hospital. They die in the field. So there's a certain amount of mortality. They don't make it. They just are found dead. They drop dead, basically. And they have fewer risk factors, at least that are known, and it's their first event. So that's an important distinction to make, or something to just kind of put in your brain. And again, the therapies are pretty similar. And for all the patients, we want to restore blood flow. We want to block the adrenergic receptor sites to keep the heart rate low. Good blood pressure, though. We don't want blood pressure to drop. And ACE inhibitor is another medicine that patients get. Do you know those drugs? You ever heard of an ACE inhibitor? You guys have farm. I know you have. I'm sure it's like, whoa. I remember having all my little farm flashcards. But those are the prils. Captopril, ramipril, enalapril, lisinopril is a real popular one you'll see. They all have the pril name. They have huge advantages, and there's huge literature so that they too are core measures for MI. What do? Well, they interrupt, without getting too fancy, a neuroendocrine cascade in the body, which is the body's normal way of saying, it's sort of like the fight or flight, like I'm going to compensate. But paradoxically, that fight or flight response actually hurts the heart over time and changes the structure of the heart, literally changes it. We want to preserve the function and structure of the heart. So giving them ACE inhibitors, which actually do lower the blood pressure, that's an immediate action. And guess what? That actually helps the heart, even if the patient isn't hypertensive. Because even lowering it a few meters of mercury for a compromised heart lowers the work the heart has to mount, or the pressure it has to mount with contraction to overcome the pressures in the aorta and inject blood. So it lowers the work burden for the heart. And then over time, it actually preserves the conformation of the heart. And there are many patients who can't take ACE. Some patients get very flush, like angioedema. That's a very profound response to ACE. We always start low and then titrate up with both beta blockers and ACE inhibitors. Other patients, we are always watching the creatinine, the kidney function, creatinine B1. We want, most patients will actually bump up a little bit and then kind of readjust down, but some patients have to be taken off because they can't tolerate it. So there's an alternative category of drugs called ACE receptor blockers. They can be put on as a second intervention. And those drugs are your sartans, like candesartan, irbesartan. Some trade names are things like Cozar. Have you ever heard of Cozar? And some of them are even combo drugs of a sartan with a HTZ, which is hydrochlorothiazide, or a diuretic drug for some patients. We always want to examine risk factors, and they may need lipid-lowering agents. And as nurses about ready to be newly minted, be watching, because the controversies and the changes in thinking are coming out all the time. Butter used to be a terrible thing. Now it's not a terrible thing anymore. But and lipid-lowering drugs can do marvelous things, but they're not a panacea, and they have a cost too. They have side effects like inflammation of the muscles, etc., or elevation in liver function indicators, liver enzymes. Management of the patient with an RV infarct. Patients who have a disruption in the right coronary, let's say an insult to the right coronary that causes the right ventricular. Remember, the right ventricle, its job is not only to pump blood to the lungs, right, for exchange of oxygen and carbon dioxide, but it's the primer. It primes. It can't deliver a good amount of blood. The left ventricle is going to suffer, because eventually that blood that was pumped by the RV to the lungs comes back through the LA to the left ventricle. And if the RV starts to fail, eventually the whole heart will fail. You'll have biventricular failure. The important thing, if you identify the person with the right ventricular infarct, which may be a little too detailed, is we don't give nitro. So we want to know, we want to look at the ECG, where is it? If we give nitro, it causes huge vasodilation, this patient's going to tank. They're going to tank really badly, and they're going to be in an ICU or CCU setting. We're going to be giving fluids and maybe dopamine, etc., trying to resuscitate them. So it's important to know where the heart insult is in the heart. And as a nurse receiving a patient who's been to cath lab for an intervention, you want to know, were they successful or unsuccessful revascularizing the lesion, etc. Were there issues? Was there a dissection of the coronary, which is actually common? Doesn't mean a completely through dissection of the coronary, but you want to know what to surveil for on your patient. And so we talked about reperfusing and revascularizing the patient presenting with ST segment elevation and none. With fibrinolytic agents, a nursing responsibility would be really to watch for what we call reperfusion arrhythmias. If a part of the heart has been starved for good blood flow and good oxygen delivery, and now is getting bathed in nice blood because of these clot-busting drugs, you will see a lot of PVCs, and you'll see a lot of, and it could be multifocal, you will see a lot of VTAC, and it can be very alarming on the monitor. But we actually expect it as long as it's managed and your patient's being very closely watched. And there may be protocols for lidocaine or antiarrhythmic therapy. So these are just some of the names of the different clot-busting drugs. And of course, besides watching for reperfusion arrhythmias, you're going to surveil the patient for bleeding, any kind of bleeding. Sometimes they'll bleed from the gums. We don't use these drugs quite as much as we used to anymore. These are IV versions of antiplatelet drug, basically like Plavix delivered IV. A lot of it's just used in the cath lab and not on the floors anymore. Angina, we want to increase blood flow. We definitely want to interrupt the fight or flight catecholamine cascade by giving morphine, and also morphine is a vasodilator, actually, too. Again, you would be very careful giving morphine or nitrates to somebody having a right ventricular infarct. And then we give the beta blocker, which is not only, you should have a beta blocker at least on board at discharge. It's a perform measure, again, for these reasons. To decrease myocardial oxygen demand, that's what NDO2 stands for, and reducing the afterload, in other words, how much pressure in the aortic system, or arterial system, that the blood has to, heart has to overcome the left side to pump blood. Question?
How are you giving the morphine?
Oh, we usually give it IV. Yeah, like a lot. You
Do
can
they
give
ever
it
do
IV.
like high dose underneath the tongue to make it instant?
We don't give out morphine. I would never give it under the tongue. I don't know where that you can, but we usually just give it IV, like a IV push, slow push. Yeah, and the paramedics will give it a lot in the field too. Percutaneous coronary interventions is a gigantic umbrella term again, talking about various therapies that a physician can do in the cath lab setting. And if you ever get a chance, I encourage you to go to a cath lab and watch a procedure. I think it's pretty interesting. Or you don't have to actually be in the room. You can actually be in the control room looking at the panels and seeing where you see actually the heart imaging and what's going on with the heart. Besides going in with a catheter and expanding a balloon to open the arteries, there are devices that can extract lasers. Some of them were developed right here in the Bay Area at Sequoia here in Redwood City by Dr. John Simpson. Brachytherapy is the use of radiation actually within the vessel to deal with lesions. Laser angioplasty, stenting, of course, which are like the little springs or internal scaffolding, and some that are very fancy that are called DES, or drug-eluting stents, that elute things like sirolimus slowly over time, which is actually an immunosuppressant to prevent, not clot, but to prevent what we call a hypoplasia. Of what happens is the body lays down new intimal layer over the struts of the stent. And that's a good thing. You want it to do that because then the body sees it. This is part of me. It's integrated into me. It's not a foreign object for which I have to take Plavix forever so I don't have a clot. But the body sometimes tends to go overboard and the person has a new lesion, what we call intimal hyperplasia, which causes another occlusion altogether for the patient, which will require another intervention. This is what it looks like for the ballooning. And it's amazing how much pressure those balloons actually exert on the arterial walls. This is an atherectomy device to actually scoop out the clot of the plaque. And this is use of laser. And this is how stents are deployed. They're collapsed with a balloon delivery device, and then the balloon is inflated, and the struts are expanded against the vessel wall, and then the catheter is withdrawn. And then what's often used is what we call IVUS, or intravascular ultrasound, to actually go in and evaluate the patency of the lumen, how open the lumen is. And they use what they call TIMI flow evaluation. So TIMI 3 is really good flow, TIMI 2 is compromised flow, TIMI 1 is pretty poor flow, so they use those designations. And these are complications of having had a percutaneous coronary intervention. You'll be watching for dysrhythmias. Vasospasm, talked about the tendency of the artery to recoil. It doesn't have to be right away, it can be hours later because it's been stretched. Dissection or interruption of the intimal layer into the medial layer. Allergic reaction to contrast. Sometimes patients are given, especially if they have renal function problems, contrast provides a load on the kidneys. So if patients have renal dysfunction, there are often some prepping that you do that's ordered for the patient prior to the procedure to mitigate the risk for damage. Atrial or ventricular perforation, that's very rare, I'm happy to say. Embolism and myocardial infarction are all possible consequences of PCI. Complications of MI, we talked about cardiac shock and of course death. CHF, which is congestive heart failure or pulmonary edema. Papillary muscle rupture, we talked about that, where it interrupts blood flow to the papillary muscles in the left ventricle that support the leaflets of the mitral valve. And an acute rupture is an acute emergency. You have acute MR. They can have pericarditis that happens after they've left the hospital and are healing at home, come back in and it's seen an x-ray. It's usually treated as an outpatient. And of course, a host of different arrhythmias depending on the location of the culprit vessel and what territory the conduction system and the heart vessel was at risk. And this is really busy, but anyway. So there are closure devices. We used to, as nurses, have to monitor the catheters that were put in the femoral artery. They go retrograde up the aorta actually, and then the dye is delivered in the coronary ostia, right outside the aortic valve. and they come to us with the sheets in place, and they don't do that anymore. They take them out in the cath lab, which is very nice of them to do because there's a lot of work. You still monitor them though. So they have closure devices to actually withdraw the catheters, and they seal it up. But as a nurse, you're going to be watching. You have a protocol every 15 minutes for the first hour, every half hour for the next hour, and then every hour for the next 4 hours. Assessing distal perfusion, color, temperature, etc., the pulses in the distal foot, looking at the incision site for signs of hematoma. You can actually bleed quite a lot into the groin before it's obvious. So, or you could develop a retroperitoneal hematoma, which is no picnic for the patient either. So there's some nursing care considerations for the patient who's had PCI. And the fact that they've also gotten a host of anti-clotting and antiplatelet drugs will, sort of promote the bleeding as well. Besides the fact that the arterial system's been breached. So you're going to be watching for rhythm and make sure they have enough fluids. We push fluids in these patients because we want to flush out that contrast medium that might hurt their kidneys. So they often get either IV fluids or oral fluids, etc. And there's a certain amount of time where they need to be resting. It's much shorter now than it used to be after the sheaths are withdrawn. So you want to look at your orders very carefully. Discharge teaching, of course, for all our patients, we as nurses own education. I think that's one of the things I love about nursing the most. I really do. Being able to educate patients and families, and it doesn't mean pulling up a chair and sitting there for half an hour, or necessarily watching a video, although I do encourage that too if you have a video system, and then you can answer questions, because usually our videos at Stanford are pretty short with the exception of just a couple, like maybe 15 minutes long. A nurse usually, especially on the evenings, they used to work 12-hour nights, you have time to sit there and then you can watch it with the family and they can bounce questions off you. But you're always educating. You're educating when you're passing meds. The patient should be telling you what that is and why they're taking it. They really should. We want our patients to know their drugs inside and out, not that I take a pink pill at 9 o'clock in the morning, as they usually tell you in the ER when you're trying to do medication reconciliation. We want them to carry a list of their drugs and the latest doses. We want to teach them when to call the doctor or 911. They should leave the clinic. They should leave the hospital. They should leave the emergency room with a number to call 24/7 if they have recurrent symptoms or they need to know who to get a hold of. That's our job. That's our job to figure out who that is and to make it part of our standard of practice. Dealing with psychosocial, emotional aspects. There's a lot of literature, particularly nursing literature actually, about depression, the role of depression. It's very common for patients with MI or cardiac surgery to deal with depression if post-event. Because, why? Well, it impacts their whole self-concept, their role in the family as breadwinner, that type of thing. There's a lot of ramifications. The good news is usually patients can be supported and go back to what they used to do, or maybe with some modification. And then cardiac rehab, we need to push that. I totally believe in cardiac rehab, not only for post-MI, post-revascularization patients. I believe in it for heart failure. It's only recently been approved by Medicare for reimbursement for heart failure. So these are all the risk factors that you guys already were able to rattle off. I'm glad that you could to me. We didn't mention alcohol. We didn't mention stress, and I don't think there's a person in this room that doesn't deal with stress. We all do. But trying to it's how we respond to it is more important than the fact that we have stress, because we're alive. We're going to have stress. Diabetes, of course, is another big risk factor that we might have mentioned. Lipids, patients should know what their cholesterol is. I know what mine is. At Stanford, actually, as employees, because they insure us, we have health fairs every year, and we're encouraged, they do for free, they do our cholesterol panel, they weigh us, and I'm happy to say I lost 25 pounds in the last 6 months.
Oh, wow. That's amazing.
And I got my cholesterol under 200, which I'm happy about too. But anyway, it's sort of mindfulness for all of ourselves and our loved ones about keeping our healthy habits. And these are typical drugs that someone would go home with after acute coronary syndrome. Not everybody will go home with sublingual nitro, but lots of patients will. And many patients will go home with statins, which not only lower your cholesterol, improve your cholesterol levels, but they improve the biology of your endothelium. There's a lot in the literature, or if you're interested in biology, but a lot about how the
endothelial layer, which, mind you, lines all our arteries, is only 1 cell thick. It's like an amazing factory that produces all these vasoreactive substances for constriction and relaxation. And they have found that statins improve vasoreactivity, basically the function of our arteries. They think that it actually may help lower chances of developing dementia, because again, the same risk factors for cardiovascular disease are associated with development of dementia, and so on. And then you can read this for yourself. But there are other non-pharmacologic therapies like smoking cessation, like cardiac rehab. Another core measure for hospitals is the physician must document left ventricular ejection fraction. That's easy to do. It's easy to assess non-invasively with just your transthoracic echo. Doesn't have to be any fancy invasive test. Of course, you can get a very definitive measurement in the cath lab with what they call a left ventriculogram, which is infusing dye during the cardiac cycle and taking pictures at the end of diastole and after systole, and you can come up with a very accurate ejection fraction, which we'll talk about more. These are the core measures for QMI that all hospitals are keeping statistics on for benchmarking. You can see those for yourself. Aspirin beta blocker, ACE inhibitors, smoking cessation counseling, and different hospitals manage that differently. We use volunteers at Stanford to come speak to the patients. I think the messaging, though, from a clinician is very powerful and needs to happen, and most nurses and or attending physicians will also mention it. And these are RN responsibilities. Assessing for chest pain or anginal equivalent. So you want to always be assessing, especially after they've had a procedure, monitoring the ECG dynamically. If there are orders for serial labs to be drawn, if they're done, because you often want to look at your cardiac bioenzymes in sequence over a period of time, like 6 hours apart, and then patient-family education. So why don't we, it's a little bit early, let's pause now, because this is a nice break period for your day. How long do they get, like, really? 15 minutes or?